Our patient has chronic back pain. Sir, how long have you had back pain for? 5 years. So just like the last patient. So the guy that we did before you, I just talked to him. His pain is gone 100%. And he's not on any pain medication. So we're just posting his video. I don't know if Sean's going to post it today or tomorrow, but he's so happy. 5 years he had pain since he fell off a ladder. And he had a fusion done 1.5 years ago. It didn't take his pain away because the surgeon didn't do the right surgery. They didn't do the wrong level. They did the L4-5. His pain was coming from L5-S1. We're going to fix your back today, okay? As long as I can get it done. So I'm going to get started. And you're going to feel a little poke and a little bit of burning under the skin. Don't get upset about it, okay? I'm just putting some numbing medicine in. You got it? All I want you to do is don't move around. Just lay still, and we'll get this surgery done, and when you wake up, you'll be much better. But if you feel pain, say ouch. Just don't move your body, okay? If you say ouch, I'll give you some more pain medicine. All right. I haven't done anything yet. All right. That's my hand pinching you. Okay. You'll feel a little stick and burn. So it's left 3-4. That's just the numbing medicine going, okay? I know it's uncomfortable, but we'll be done soon. We're almost done on the left side. I'm going to numb your right side up as well, okay? All right. The right side is 4551. Yes, little stick and burn. Now, folks, where you go in for the surgery, where I make my starting incision, I know I don't have many marks on it, but there's a very specific area that I use. 9 cc's injected, and there's actually a mathematical way of figuring it out using x-rays that uses lines and intersections, which I don't do anymore because I've been pretty good at figuring it out without it. Long story short, I'm not just going in some random place. I'm going into a very specific area that I know based on many years of doing this surgery. 16 years I'm going on. All right, remember, let me know if it hurts. I'm giving you some numbing medicine right now, Sean. All right, very good. I'll give that a minute to work. Let's go to a lateral. So our patient here has, unlike the last patient who had 1 bad disc causing his back pain, this patient has 3 discs that are damaged, causing back pain. We call those damaged discs herniated discs. Another name is bulging discs. So he has 3 injured, damaged discs, herniated, bulging, ruptured, degenerated, whatever you want to call it, doesn't matter. It's all the same thing. Basically, it's a tear in the back of the disc that needs to be repaired to get rid of the back pain. Deuk Spine Institute's the first place in the world that identified this. Nobody else knows that it's the tear in the back of the disc called the annular tear that's the cause of the back pain. I discovered that. I discovered it about 16 years ago. I published it in 2012 for the first time in the National Library of Medicine in PubMed. It's indexed. And nobody else still has really listened to me and started doing these surgeries, Shot. Other surgeons don't know that the pain can be cured with surgery. Shot. So where do you feel that? Huh? But not down your leg. I couldn't hear a word. Yes, sir. Lay still. Don't try to lift your head up. The anesthesiologist is going to tell me everything you say. You don't need to worry about it, okay? But I just don't want you moving around. It makes my job harder. So, do you have pain going down your leg? No. Good. So we're in the foramen. I'm right here, where I want to be. Shot. And we're just about done. So the needle is touching the back of the disc. You can actually see the herniation on the x-ray. Go AP. Let's make sure everything looks good. I felt like his facet deflected my needle a little bit laterally. I want to make sure it's still in an acceptable position. So I'm going to get an AP view. The AP will tell me about lateral deflections. I'm not looking forward to L3-S1. That's perfect. Look at that. That's absolutely perfect positioning of the needle. You can see the pedicle above at L3, the pedicle below at L4, and the needle tip is exactly where the herniation is, where the annular tear is at 3-4. Okay? So let's go back to a lateral view. Very nice job on the x-ray. Let's draw some pictures. The light situation. All right, are you on the eye in the sky?
Yes, I am.
Are you comfortable? Oh yeah, I need to do a quick lateral view. We're going to position this in the final place. Shot. All right. You comfortable? As comfortable as you could be in an operating room, right? Plural. Shot. Perfect. Okay, so just so everybody can see, this line is the midline. The disc that we're going to fix, there's a bone right here. That's called the L3. And there's a disc between the L3 and the L4. And then there's an L4 bone right there. Okay. L4. And this cushion between these two bones is called the L3-4 disc. And this patient has a tear right here on the left side. This is the left side. This is the right side. He's got a tear right here. You're going to enjoy watching this later, by the way. And my needle just went into that tear. And the needle is sitting right here inside the disc. We're going to do a discogram in a few minutes. We're going to test this disc to see how painful it is, all right? But I got to get to the L4-5 disc, which is below. And then there's the L5 vertebral body right there. And then we got one last disc. It's called the L3-S1. And then we have the sacrum, which is the tailbone right here, okay? This is called the sacrum. So we've got a tear on the right side at 5-1, on the right side at 4-5, and on the left side at 3-4. You like that? Okay. So I need to go to the other side in order to place the other two needles. Yeah, did I tell you the patient we just finished literally 30 minutes ago? He's already dressed and he's already on his way home. 30 minutes ago. His recovery was 30 minutes. Your recovery is going to be 30 minutes too, just as long as you don't keep moving around. Alrighty then. You comfortable? All right. Remember, if it hurts, you say ouch, and I'll give you some more numbing medicine. Just try to lay still. Don't move your body around. We're going to have you asleep very shortly, and then when you wake up, we'll be done. You'll have a new lease on life with a new back. All right, I apologize. People think you can't cure back pain. And we're going to change their perception about that. Because the truth is we can. Okay, I need you to come off of the eye in the sky here, and I need to go to the x-ray. All right, so there's too much light in this room. I need you to line up 5-1 for me. Your pedicles are a little bit off, so you're going to have to wag a little bit, and your iliac crests are a little off. You're about 1.5 degrees off. And then we're going to have to orbit rotate. Just pick one way or then the other. Go. Shot. That's better. So you chose right. And now rotate, I would say maybe bring that side up The left side up, that side up. A little bit, like a degree. Let's see where we are. By the way, look at the L3-S1 disc. I think that's better, but let's go a little more. It may be worse. I can't really tell. Ooh, I think it's worse. Let's go the other way. I could be wrong, but let's just try it. I think that's maybe better. L3-S1 is horrible. So let's keep going a little more. Let's see what happens. This is due to scoliosis. That's why we're having a hard time lining things up. Well, I know it doesn't look very good, but that may actually be good enough. The part of the problem why things don't look so good, folks, is that he has short pedicles. And the short pedicles make it really hard to get it lined up. All right, let's try going the other way again, just to make sure. On the orbit.
We have a question.
Shot. Not just yet. And back the other way. Yeah, what's the question?
One of our viewers on Periscope is just wondering, how long do out-of-state patients have to stay in town before they travel back home?
So if you're traveling from out of state for the Deuk Laser Disc Repair surgery, you can go home the next day in the evening. So you come in on Sunday or Monday morning. You come to clinic here on Monday afternoon. Get your, if you have all your pre-op clearance, you don't need to worry about it. But if you don't have pre-op clearance, then we need to do it here. In which case you should come Monday morning early. So come in Sunday night, be here in clinic Monday to see me, meet the doctors, have an exam, go over the plan, sign all the paperwork. Tuesday is surgery day, and Wednesday night you can go home. Come in the office Wednesday morning, get for a checkup, and then go home Wednesday evening. All right, let me see here. I think we've overshot it, to be honest with you here. Let's first do a little wagging, because I don't feel like we got the end plates lined up. So we need to wag one way or the other. Just pick away and see if it gets better. Go. Shot. That kind of looks a little better. What do you think, Luis? Yeah, but I think we need to bring that side up. And shot. Oh yeah, that's definitely better. That's definitely better. I think we're awfully close there. I know that the pelvic bones aren't perfectly lined up, but I think we should, all right, let's try one more degree. If we don't get it, go back to where you are right now. Actually, that's about as good as it's going to get, right there. Lock her in. Lock it in. All right, don't move, okay? We got everything set up perfect. If you lay still, then we can get this done. Shot. Need a shot? Yeah. I know it's a little uncomfortable, but shot. Give me an AP. Yep, AP. So I'm trying to get into the 5-1 disc space. And before I do any navigating, I need to make sure that the needle is, that's good. Make sure the spine is lined up properly. Go back to a lateral. That the spine is lined up properly with the fluoro. Yeah, go, go, go. You're doing good so far. If the surgeon doesn't have the fluoro lined up properly, then you're going to be seeing joints at an angle that you shouldn't be seeing them at. And that's really bad. We don't want that. Shot. So I need to make sure the fluoro is in proper position, that I have reliable navigation information. It would be like having, somehow he moved again. You didn't move? Then it's us. Shot. Getting closer. Where do you feel that, Sean? Where? Not down your leg. Huh? We're awfully close. Oh, there we go. It's amazing. I can feel that it go through the tear. Now look at 5-1, folks. Now you're going to move up to 4-5. I'd move just a little bit, like about an inch up there. Just take a look at that x-ray at 5-1. Look at that white area between the L5 and the S1, okay? That's called vacuum space phenomena. There's literally a vacuum of air in there. And if I could open the needle right now and you'll hear a hissing sound. No, that was the needle sliding. All right, normally you can hear a hissing sound. But there's literally a gas, a negative pressure gas pocket in there. Anyway, I didn't make this stuff up. That's something that other people described before me. Okay, let's wag Luisa's side north a little bit because we're offset on the pedicles at L4. And I want to get those pedicles right. Vacuum space phenomena. I think radiologists were the first ones to describe that in the spine. And it just means, oh, that's perfect. It just means a degenerative condition, that's severe degeneration of the disc at L5-S1. So we're going to fix that pain from that disc today with this surgery without doing fusion. Okay? We're almost done and we're going to put you to sleep soon. Okay? You're doing great, by the way. You're doing everything I need you to do, so thank you. Except the bleeding. You're not allowed to bleed. Okay? I don't want you bleeding. If you bleed, I have to charge you extra. I'm just joking. I'm glad he's laughing, right? See, I mean, people wonder why do you have to be awake, Dr. Deuk? Well, why do you get to be awake? That's what you really should be asking yourself. Do you get my jokes? You know, you get my stand-up comedy, right? We're almost done. You've been so good to me, and I really appreciate it. Yeah, I know, that's the bad disc, isn't it, Sean? Yeah, I'm sure of it. All right. See if I can do a better job. All right. So you've been really good. We're going to put you to sleep soon, okay? In like just 2 minutes. But I need your help for something. Have you ever watched the surgery being done? All right. Do you remember what we do next? Put a little pressure here for me. What did he say?
Make it sore.
Yeah, you're right. Not many people remember this part. I don't think they want to remember it, but I need to make sure we're in the right spot. Remember? How bad is that on a scale of 1 to 10? What did he say? What? Childbirth? All right. Was that where you typically get your back pain? All right, so concordant, childbirth. Would that be a 10 out of 10 or something less? Be careful how you answer this question. There are a lot of ladies watching. They're going to take offense to your answer if you don't say it's 10 out of 10. I can tell you that right now. He said 10 out of 10? All right. That's okay because that's the disc we thought was causing your left leg pain, remember? That was the L3-4, so I was right about it. They say it's better to be lucky than good. All right, is it better now? So folks, we did a discogram at L3-4. He had back pain, left leg pain. That's the one right here. And we're going to call it a 10 out of 10. All right, so I'm going to point here. You all see this, Sean? This tear in this disc at L3-4, it was a 10 over 10. We call it childbirth. Now, have you ever given birth to a child? Do we have epinephrine in here?
Yes, sir. And this is
Why am I getting...
this off. That's fine. This off.
All right, so this is the childbirth. disc right here. You all see this here, this disc?
Yes,
You
we can.
okay? And there's a little baby, a little infant right there to remind us. Okay? Are you better? How bad is that on a scale of 1 to 10? 10? That was your L4-5. I know it might seem to you that I'm just torturing you, but I'm not. I'm verifying that we are fixing the discs that are causing your pain. Now, for anybody out there in the world that thinks that degenerated discs, herniated discs don't cause back pain, the discogram is the one test that will show you it does. All right, you better? Let me write that one too. That was a 10 out of 10. Now, how many discs are we fixing today? How many? How many discs have we tested so far? Huh? 2? You're good at math. How bad is that on a scale of 1 to 10? All right. I apologize. Guess what? You get to go to sleep, and when you wake up, we'll be done. And that pain will be gone for the rest of your life, as long as you don't do anything foolish, like bending over, picking things up after surgery like you shouldn't. All right? Just follow my instructions, and that pain will be gone the rest of your life. So, another 10 over 10. Just count out loud for us from 1 to 100, and when you wake up, the pain will be gone. Isn't that incredible, folks? Nowhere else in the world will you ever see this kind of surgery done. Back pain eliminating, curing surgery. Count out loud from 1 to 100. What languages do you speak? I know you speak more than English. Huh? I can't hear him, Pettit.
He's speaking German, it sounds like.
I don't think it's German. Dutch. Dutch is good. Yeah, I am actually 1/8 Dutch. Nice and loud. All right, shot. So, our patient is clearly. Have you been to Amsterdam, or are you from Amsterdam? I shouldn't assume it's Amsterdam, right? Amsterdam's not the only country. He's asleep. He's a world traveler. Yeah, that's no surprise to me. I'm not sure what language they speak in Zimbabwe. Anybody know? Sean? Can you enlighten us? But I know he's been all over the world. He's well traveled. He came to Deuk Spine because he learned about the Deuk Laser Disc Repair surgery that I do right now, that he's getting, that will cure his back pain. Folks, if you've been told out there by your doctor there's no cure for your pain in your back or neck, don't listen to them. There is. It's right here at Deuk Spine Institute. You don't have to live in pain anymore. Shot. We are doing these surgeries just about every week now. Yeah, I know, I'm sorry. Let me know when I can proceed. So we're going to fix this disc first. That's the, I think we need multicolored pins. Okay. Let's get some red pins, and the purple's fine. Maybe some other like orange, I kind of like this. It's good for educating people. What do you think, Sean?
Yeah, it looks good.
Right? Yeah. All right, take it easy. Let me know. Can I proceed, or you want me to wait a few minutes? I'll wait for just a minute. No problem. So we're at the back of the L3-S1 disc on the right side. This is the middle of the patient's back. Remember, they're laying face down. This is the patient's right flank, and I've made a 7 mm incision. I'm going to repair the L4-5 and L5-S1 discs. They're both herniated and degenerated. We're using the Deuk Laser Disc Repair, a procedure that was really pioneered here by myself, the pioneer and founder of the procedure and the institute. And this should eliminate, it will eliminate the pain coming from these two discs. And then we're going to go to the left side and we're going to get rid of the childbirth disc. It turns out they're all 10 out of 10 pain, but that was the childbirth disc. Can I proceed? Yes or no?
Yes.
Shot. I know this bothers some people to watch this. It's the only way to get in is to use a to use a mallet. I'm so glad he's asleep, because he wouldn't have been able to tolerate that otherwise. Now, people always ask me, Dr. Deuk, if we lose weight, will that get rid of my back pain? No. People that have back pain are, many times they're overweight, but it's really because of their inactivity, because their back hurts so much when they do anything. So it's not the overweight that caused the back pain, it's the back pain that causes the overweight. Shot? I got to make sure my dilator doesn't go forward any more than it is. Otherwise we'll be in the pelvis, and I don't want to be there. Shot? I'm not a pelvic surgeon. Okay, let's pull the dilator back a little bit just to be safe. Shot? I think I pulled it just a little bit. Problem is it's stuck on the tube. Yeah. Shot. That's better. Problem is this damn tube is stuck on there. If I pull backward. Take that. All right, let's try again. Let me see. Shot? No. Let me try to pull the tube back again. Let me try to pull the tube back. I need a dry Raytech, not a wet one. There we go. Oh, good. Shot? Yes. That's what I want to see. So you see how I tapped it, the dilator in a little bit just to free up the soft tissue that was. Sometimes what happens is as you're putting, can you see this, Sean?
Yes, we can.
As you're putting the tube down the dilator, a little bit of like fat or stuff gets stuck in there, and then you basically weld the two pieces of metal together when you shouldn't be welded together. Shot? Shot? All right, that's good. It's not really welded, but I think it's called cold welding. Shot? And I'm not even sure that's correct. We'll just call it soft tissue welding. Okay? But you got to be able to deal with it effectively. And let's get the fluoro out. So I'm in a good way into this disc. Quicker. No, that's not what you do. You pull it back there and turn it. All right. So. I'm going to be working right here, so yeah, I do. But just don't let it get, that's fine. It's just good enough. Don't let it get contaminated. Blue towel here. So now we're going to head down through this little tube. This tube, remember, connects the surgical field where we have all of our special instruments to do the surgery to the disc, right into the annular tear. Okay, and the blue stuff is the dye that we put in. That's our Deuk spine dye. Grab her. And what we're looking at is basically degenerated nucleus pulposus. Leave it. Degenerated nucleus pulposus. Okay? Why is it degenerated? Because it was damaged. That's herniation right there. Now it's not inside the disc normally. I just shoved it back in there when I went in with my dilator. And that's the technique I use is called the inside out. We start inside the disc, below the herniation at the base of it, and we basically remove it from the base to the tip. The tip being in the epidural space. Okay? So this is the first of 3 discs that we're going to fix today for this patient. All 3 were causing pain for him. We verified that with the intraoperative discogram. Discogram is a great procedure. See all the little black marks? That's from the laser melting the steel of this tube. As the laser emits the energy pulse, it causes a pressure wave or a shock wave in the fluid down here. And that displaces the fiber to the side. Let me wipe this.
We have a question.
Yes.
A viewer from YouTube is wondering, how is laser surgery different than a discectomy?
How is laser surgery different than a discectomy? Great question. So a discectomy is a procedure that's first of all open, meaning you have a big incision on your back. With laser, we don't make a big incision, we make a small incision. A discectomy involves peeling the muscle off the spine to get down to the bone in the back of the disc. We don't peel any muscle off the spine with the Deuk Laser Disc Repair. We use a tube that spreads the muscle, but we're not peeling it off the spine. And then with a discectomy, the surgeon will then drill a hole, drill a hole in the back of your bone, in the backbone of your spine, called a laminotomy. Okay, that's where he removes the bone in the back. When they take that bone out, it weakens your spine and it hurts your spine. It makes it damaged permanently. It'll never grow back. It'll never repair itself, ever. Okay? The laminotomy hole in your spine, you can see it 50 years later on an MRI because it never repairs itself. You'll always have a hole. Now, they also take, in the endoscopic surgery you're watching now, we don't take any bone out. So we don't remove any bone from the spine. With a discectomy, the surgeon not only takes the lamina out, but also they remove part of your facet joint. It's called a partial facetectomy. Partial facetectomy. 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 Basically, ectomy means to remove from the body. It's a medical term. It's Latin. It means to remove. A facetectomy and a laminectomy means to remove part of the facet joint and the lamina. So they're removing part of your normal stabilizing bones and joints that protect your nerves and spine. They have to take that out just to get to the herniation for the discectomy. With the laser surgery, the Deuk Laser Disc Repair you're watching now, it's a revolutionary technique. We don't take the bone out. We don't take the facet out. We go around the side through a hole that's already there. That hole is called the neuroforamen. God put that hole there. That's where the nerves come out. The same nerves that are being pinched and irritated by the herniation. The reason other surgeons don't do this is they don't know how to do this surgery. It's more complicated than a discectomy. A discectomy is a very easy surgery to do. A endoscopic surgery like this is extremely complex, very difficult, and only the best surgeons can do this kind of surgery. About 95% of spine surgeons can't do it. They don't know how to do it. They'd like to do it, but they don't know how to do it. They've never been trained to do it. And it's a much more complicated surgery to do, what I'm doing. I do discectomies. I've been trained on discectomies, but I don't do them because they're bad surgery. The next thing that's different is once you get past the bone, with a discectomy, the surgeon is going to take ligaments out of your spine. Ligamentum flavum. They have to remove that ligament to get to the disc. With the Deuk Laser Disc Repair, we don't take the ligaments out. We leave them there. The ligaments stabilize your spine and keep it stable so it doesn't wobble around. When you start taking the facet joint out, the lamina out, the ligaments out, the spine starts to get weak and wobbly. Then you're going to need a fusion done. Okay? So that's another difference. With a discectomy, also, not only you're removing bone and ligaments and joints that are natural and normal, should be there, shouldn't take them out, damage them, but you're also going to be retracting the nerve root hard. You're going to have to take that nerve root and push it over to the side. And then, at a discectomy, you're going to blindly reach around the nerve root and hope to God you can get a piece of that herniation. But you really can't see what you're doing. It's a blind surgery. Okay? With the Deuk Laser Disc Repair that you're watching, there's nothing blind about this. Everything we're removing we can see with the endoscope clearly. A discectomy doesn't use an endoscope. Okay? So those are just a few of the differences, including that a microdiscectomy or discectomy you're talking about doesn't fix back pain, ever. A discectomy fixes leg pain, leg weakness, leg numbness, tingling in the leg. We call those radicular symptoms. Pain down the leg, weakness in the leg, numbness in the leg, tingling in the leg. Those four things. Pain, numbness, tingling, weakness. They're called radiculopathy. So a discectomy fixes radiculopathy. It does not fix back pain. Radiculopathy does not cause back pain. Radiculopathy has nothing to do with back pain. The only way to fix the back pain is to treat the disc tear, the tear in the back of the disc. And that's what the Deuk Laser Disc Repair does. Microdiscectomy does not do that. Sometimes the surgeon will get lucky and the patient will get some back pain relief with a discectomy, but it's not common. And a surgeon will never tell you that have a discectomy done to get rid of your back pain or neck pain, because they know that you don't do discectomy for back pain and neck pain. You understand? Think about back pain as being thirsty and leg pain as being hungry. When you come to Deuk Spine, you leave not thirsty and not hungry, because we fix both, your thirst and your hunger. On the other hand, discectomy only treats the leg symptoms, which is, what do we say that was, hunger? But not thirst, which is your back pain. Maybe that's not a good analogy, but it's the best I could think of right now. Sorry, I can't do better at this moment. I hope you understand the difference. And what I'm trying to illustrate is, number one, everybody knows what thirst and hunger are, right? We've all been thirsty, we've all been hungry. If you're thirsty and you eat a sandwich, you're still going to be thirsty. If you're hungry and you drink a glass of water, you're still going to be hungry. Because fixing your thirst side doesn't fix the hunger side, and fixing the hunger side doesn't fix the thirst side, unless you're really wired weird. But for most people, When you're thirsty, you drink. When you're hungry, you eat. So the fact is that people with disc problems that need discectomies and laser surgery like this, they're people that have hunger and thirst, both. They need a procedure to fix the back pain and a procedure to fix, and a procedure to fix the leg symptoms. But a discectomy only fixes leg symptoms. And by the way, you could apply the same to the neck. If you're having neck pain versus arm pain, surgeons won't operate on you for neck pain. Surgeons won't operate on you for back pain. They operate on you for leg pain or for arm pain. Does that make sense? We call it radiculopathy. That's because surgeons are taught they can't cure back pain, they can't cure neck pain with surgery. So they truly believe that. And that's a myth. And they perpetuate that myth. I have so many patients that have come here from other places. Look at that tear right there. That is the annular tear. It's a really good image of one. It's very inflamed. That's what all that red and pink is. So this is what I'm here to fix. And this surgery you're watching, the laser surgery that I do, is the only surgery in the world that fixes this tear. No other surgery does. Discectomy does not clean up this tear. Discectomy removes a piece of disc material that's stuck up against the nerve, outside of the disc. We are inside the disc. We are not outside the disc. We are inside the disc. I am operating inside the disc. Discectomy operates outside the disc. It only takes the piece of disc material outside the disc, but it leaves. Now, if you think about a disc herniation being like an iceberg, the part that's outside of the water is 10%. 90% of it is underwater. I think I got my percentages correct. It's been a while. So it's a 90-10. The herniation is actually inside the disc, inside the annulus fibrosus, the tear. It's called interposed herniation. And that's what a discectomy doesn't treat. It doesn't treat the interposed herniation. It only treats the extruded disc material. And that's the part that's extruded outside the disc. So that's why discectomy is not a good surgery. I don't recommend it on anybody. It's an old surgery, but it's the only thing most spine surgeons know how to do around the world. So that's all they're going to offer you, is a microdiscectomy to fix your leg symptoms. But if you want to get rid of your back pain and your leg pain the right way, without having damage to your spine from the surgery itself, you want this surgery, the Deuk Laser Disc Repair. I hope that answers it. There's a piece of herniation there that just got loose. So the most advanced aircraft in the world now are these high altitude drones. They're all remotely controlled by the military. They are armed and capable of launching even a nuclear bomb. Unmanned. Small. They are literally the most advanced, technologically advanced aircraft in the world now, more so than even a stealth bomber. And everyone wants the drones, but only a few countries have them because their sale is restricted. But the point is, they're very expensive, very technologically advanced. This surgery you're watching is like a high altitude drone. This is the most advanced, most technical surgery for the spine in the world. It's the least invasive also. Those drones are small. They're not like a big, bomber, stealth bomber. They're tiny. And the incision we're using today is tiny. We're going in with a drone. All right? The problem is not everybody has access to drone technology. So let's just say that the 10 most developed countries in the world have access to drone technology. It's the same thing in spine surgery. There's thousands of spine surgeons around the world, just like there's thousands of countries around the world. But only a few of them have this technology. They have the drone technology. Only a few surgeons have endoscopic transforaminal technology like this. We've been doing it now. We were the first. We were the drone creators. All right, we were the first ones to militarize a drone, and we're the most advanced. We've been doing this research now for 16 years. So the rest of the world has got, my God, if I'm not going to sell them my technology, but we actually are. We're showing you how to do it on the internet for free. But let's pretend that we didn't. It would take those countries another 20 or 30 years to develop the drone technology that the United States has, okay, independently on their own. So I'm actually showing you how to build a drone right now with this free broadcast. And you know how many surgeons contact me and say, hey, my God, what you're doing is amazing. Would you be willing to help us build our own drone? You know how many have done that? None. Why? For a lot of reasons. We've talked about it other surgeries. I don't want to go into again. I've talked about it ad nauseum. But it has to do with basically the companies that sell the existing stealth bomber, let's just say Lockheed Martin. They don't want to give up the contract they have with the government of these countries to sell stealth bombers. That's an older technology. It used to be like the best technology. So microdiscectomies, fusions, artificial discs, those are really now old technologies because this surgery has made them old and far less effective, far less efficient, far more expensive, far less reliable. Whereas my surgery here you're watching is the most reliable, least invasive, least expensive, most successful of all surgeries of the spine.
We have another question.
Yes.
Similar to the last one, the viewer is wondering, what about the difference between a DLDR and a percutaneous discectomy, endoscopic percutaneous discectomy?
Yeah, so great question. Percutaneous means it's done with a needle. And there is one type of an endoscope that's really bad quality that goes down a needle, and you can't really see very well. But it's done through a needle. Obviously, we're not doing this surgery through a needle, so there's one difference right there. And then the discectomy, again, is where you take out the mushroom top of the disc, herniation, but you don't take the stalk out. So taking the stalk out of the mushroom, not just the cap, the stalk is this surgery here. Nobody else takes the stalk out. I was the stalk remover, the first stalk remover, and the Deuk Laser Disc Repair is the first and only surgery published in medical literature that takes the stalk out. There is no other surgery that takes this stalk right here out. See, this is not part of the herniation. It is part of the internal herniation, but not the external. And a discectomy, an endoscopic percutaneous discectomy, they just work on the external herniation. They don't do an annular debridement. An annular debridement is what I've been doing for the last 20 minutes that I've been in here. This patient didn't have a big disc herniation. He didn't need a discectomy, a traditional discectomy. He needed this, annular debridement right here. And this is not part of a discectomy surgery. There is no surgery but the Deuk Laser Disc Repair that does what we're doing right now. In a way, you can think of it as, what's the difference between a ship and a submarine? Well, they're very different, okay? And the ship is on top of the water and the submarine is below. And they're equipped very differently. They're built very differently. even though they're both very close, they're both in the water, and they both, you know, go in the ocean, but that's about it. They both have an engine. You know, they both have sailors, but, you know, there's too many differences, even though you think they both would be very similar. The main difference is I do an annular debridement, and discectomy just takes the herniation fragment out. They don't do an annular debridement. If you don't do the annular debridement, you don't get rid of the back pain. The alternative would be to fuse this disc. See that pink stuff right there that I'm zapping out? That is granulation tissue. That is the inflamed tissues. Not the bleeding stuff, but I'm talking about the pink stuff in the annular tear that I've been zapping with the laser. All right, this is taking a little longer than I expected because it's a pretty big herniation. And the herniation I'm talking about is this part from here down to here. This is called the interposed herniation. It's the part that nobody ever talks about or does anything about. You don't treat from here to here with a microdiscectomy or discectomy. You only treat from here to here. From here to here with a discectomy. I don't know if that helps. Hopefully it does. We are actually inside the disc treating. And I'm just about done. We've got rid of most of this. I'm trying not to pull on my scope because that will break it. Oh yeah. A broken scope is thousands of dollars to fix. We don't want that. Just about done. Good questions today, folks. Good questions. All right, let me see the grabber. Just about done at L3-S1, and then we're going to move to L4-5. And we're going to do last will be L3-4. Laser. Just about done here. I need about another minute, and then we're going to come out of L3-S1 and we're going to fix the next disc, which will be, as I said, the L4-5, and the last disc we fix will be 3-4. L3-4, the top one on the left side. Remember when I did the discogram, the patient actually said, "Oh, I feel it down my left leg." That's why we went to the left side at L3-4 and not just doing the right side, because he had left leg pain, and it wasn't coming from L4-5, L3-S1 based on his MRI. It was actually coming, in my opinion, from L3-4. So that's why we did the L3-4 as well, from the left side, not the right side. You gotta not just figure out which discs are causing back pain, but you gotta figure out which discs are causing the leg symptoms. And you gotta treat that side. All right, it looks good. Happy with that? Maybe we can see the nerve root right there. It's buried in fat. Okay, we're done. There, scope off. Endoscope off. Yep. Turn the scope off. Hello, McFly. Okay, you all see this here? Tube coming out of the skin. Sean, you see that?
Yes, we do.
So let me show the audience. Go ahead. Mm-hmm. You all see this tube?
Yes.
We did the whole surgery through this little tube right here. Beautiful. All right. Let's get the fluoro in. And we're going to do the L4-5 next. Then Remember, the arm is right there, so you want to be south of that. By the way, I have a little secret. When you're moving the floor around, you'll figure it out at some point. You don't have to go this way and then this way. You can actually turn the wheels and go that way. Does that make sense? What is it?
Going towards you just a little bit more.
You need to go in more. You need to go in a bit more.
The first patient home,
Yeah.
is he able to go home?
No. I want to see him before he goes home. You need to go in more. Come on, let's go. Push it in.
It goes in this way. I have it taped.
Lean out, look inside, on there, make sure it's not stuck. Okay, so, okay, this way? Alright.
All right. All right. Whenever you're ready. Nice. So we're going to be taking the spinal needle out. We have the guide wire there. Shot. Let's make sure it hasn't moved. Looks good. Now we're going to navigate down the guide wire. Do you need us?
Well, I just wanted to let you know that the physiotherapist is great. He's ambulated, walked, voided, had all
What are you lobbying for?
the,
You want to send him home?
yeah,
Yeah, but I want to see him.
okay.
Is he? Is the nurse here?
No, she's waiting at the house.
All right. You sure he's ready to go? Go ahead and send him.
If we're sure we
I'm fine. Yeah. Is the PA here?
can have him come over.
Why don't you call him, see him if he's here, have him check on him, and then we can send him home. Yeah, that's the posterior cervical fusion. It's your first one with me, right? So that's fine. Huh? You've probably never seen that done outpatient.
Maybe skin pain.
Get out of here. Don't make me bound and gag you. Skin pain. It's not skin, it's muscle. It's muscle. I promise you. I could cut people that long and it won't bother them. An hour later. It's muscle. It's not even the spine, it's just the muscle. Shot. There we go. Take that. It's all muscle. Most people don't know that. You know that? They don't know it's muscle pain. That is the secret. Mm-hmm. Hmm? Yeah. All right. Hope you're enjoying the surgery. Shot. There's a little bit of listhesis at this level for those of you who have noticed. It's a grade 1 spondy. Shot. Spondylolisthesis. Sponda means bone. Listhesis means slide. All it means is that the bones are sliding on each other. No big deal. Honestly, we don't need to fix it. You don't need to fuse every spondylolisthesis. As a matter of fact, I don't fuse any. And shot. And we're just going to repair the annular tear without fixing a spondylolisthesis. And this patient's pain, I guarantee you, will be gone. Guaranteed. Without fusing him. The last patient had a fall off a ladder. He had horrible back pain. He had a spondylolisthesis just like this patient at 4-5, L4-L5. The surgeon fused him a year and a half ago. He had zero improvement from that fusion. I didn't do it, someone else did it. I never would have done it. Anyway, because his pain was coming from the bottom disc, L5-S1.
You got it?
PA has already left the building, so the patient said he'll just wait for you to come see him. It's fine with waiting, he said.
Well, we're going to be a while. If he's stable and ready to go home, let him go home. Yeah.
Scope on, please.
Just send him home. And that PA. Yeah.
Scope on, please. Yeah.
You know what I'm thinking.
How long's his first day?
His first week. He doesn't understand. Clearly. I'll let today slip. You don't go home until you come talk to me and make sure there's nothing for you to do. So,
Barney,
anyway.
lights off, please.
I remember as a resident in neurosurgery, the first time I went home when I thought my work was done and how I was corrected. I was done at like 6:37. I'm like, oh, it's a long day. I'm going home, 7. And then I got called back in at about 8 by my senior resident saying, where the fuck are you? And when I got there, I'm like, yes, I'm back. Don't you ever leave this hospital without checking with me first. You know? And as a neurosurgeon, that's what they do. Anyway, I was there until 2 in the morning that night. And pretty much every night. Because what I didn't realize is that, hey, it's a team approach. And I may be done with my patients, but I got to go take care of everybody else's patients too, because they're in the operating room. I would routinely do 110 hours a week. Some weeks I did 120 hours. 120 hours, 110 to 120 hours for about 6 years. That's what residency in neurosurgery is.
Yes.
And that's not sitting around, folks. As a neurosurgery resident, we used to eat our dinner while we're walking. We would eat Wendy's while we were walking from one patient to the next. That's how challenging and difficult it is. And it's not unique to neurosurgery. I mean, general surgery is the same way. Cardiothoracic surgery the same way. Pretty much most of the surgical fields are extremely brutal. And normal people have no concept of what we go through as surgeons in our training. And I know they've made it easier over the last few years. They've put restrictions on the number of hours we can work. They've restricted us to 88 hours, almost 90 hours a week. And it used to be worse, like I said. I think they even did a study showing that there was no improvement in patient care outcomes when the residents had their hours restricted. But they pretty much made it a requirement for residency programs to maintain their accreditation. They had to comply with the American College of Graduate Medical Education, the ACGME, and the ACGME required 88 hours max a week. Shoot for 80, but maximum 88 for what's called continuity of care. Anyway, my PA has a lot to learn. But I'll give him a break because he just started. All right, all the bubbles, folks, was because we just switched my irrigation bag. But it highlights the fact that we have fluid pouring through this tube. And the fluid is basically sweeping out all the debris created by the laser. You can't appreciate it. But you see all that stuff there? That's all material that suddenly clouds your view. That's not bubbles, it's material from the disc, okay? And if I freeze that, you'll see a bunch of pieces of disc material in there. Those are from the herniation and the annular debridement. All right, Sean, any questions? There's a piece of herniation there.
We have a viewer from Facebook who's wondering, how does the disc regenerate itself after the surgery?
How does the disc regenerate itself after the surgery? Great question. So we're removing the herniation and we're cleaning up the tear. The tear will heal itself after the Deuk Laser Disc Repair. The Deuk Laser Disc Repair is the only surgery in the world designed to clean up the tear so that it will heal itself. But at your body, it just will heal. It's kind of like if I cut your skin with a blade, that skin will heal on its own. That's natural part of healing. It'll grow back together. So this tear right here wants to grow back together, but it can't because the herniation from the jelly in the middle is stuck in there, and it's keeping the tear from growing back together. I'm going in with a laser, removing the pieces of herniation that are stuck inside the tear, and that's what's called the annular debridement. I'm the first in the world to ever describe this procedure, and the first in the world to be able to cure back pain with it. We also cure neck pain with herniated discs as well, for the same reason. We're debriding the tear, letting it heal finally. The reason why there's so much pain in these tears is there's inflammation in them. It's the inflammation inside the tear from the annulus trying to heal on its own, trying to grow back together with the other side. It's trying to grow back together, but it can't because it's got that jelly wedged in there. Again, we're the first to describe that. So if you're trying to find this information from other doctors, you're not going to, because they don't know the truth. They don't know the facts about why spines are painful. They were never taught it. So how could they be expected to know it? They can't. They never figured it out on their own, and they were never taught it. They're not going to know it. It's simple. There's lots of things I don't know in the world because I never learned how to do or anything about it, and I never figured it out on my own. We all have many, many things we don't know. Doctors are the same way. Doctors don't know everything. We're not born with the knowledge. You either have to learn it in med school, residency, or you have to discover it yourself. And most doctors do very little discovering themselves. They're not pioneers. Most doctors just do what they're told to do. And unfortunately, doing what you're told to do is how bad things perpetuate themselves. You understand? It's only when people start thinking, using their brain, their God-given brain, to solve problems by understanding what's happening and exploring different ways of treating it. That's when you start making progress in science, and that's what we've done here at Deuk Spine. We figured out back pain was coming from this right here, this tear you're looking at, and that when I clean up the tear with a laser like I'm doing right now, the pain goes away. And it all makes sense. When you start thinking about the nerves that are in this area and where they go inside the brain, and how inflammation right here inside this area, which we're looking at right there, scar tissue from inflammation, you start to understand the relationship between the inflammation, the nerves, and the parts of the brain that allow patients to, or people to perceive pain as highly localized pain, aka the primary somatosensory cortex of the brain. So the nerves to this part of the disc, the back part of the disc, go to the part of the brain that allows the human being to know where pain is coming from. That's called the primary somatosensory cortex. Not just pain, of course, but other feelings as well, like cold, temperature changes basically, and what's called proprioception, which is your ability to know where your limbs are in space. Is your thumb up? Is your thumb down? We call that proprioceptive information. And of course, discriminative touch, it all goes to that part of the brain, but so does pain. Pain goes to that same area that allows you to figure out if you're holding a quarter versus holding a nickel. To discriminate between different objects. That part of the brain is a highly developed area, and it's capable of immense processing of information. Hence, it gives you incredibly rich sensory experience. For those of you who have not heard me talking about the brain before, understand that I am a brain surgeon, first and foremost. That's how I became a spine surgeon. Neurosurgeons take care of brains and spines and nerves. And I ended up just kind of focusing on spines, but of course I've had all the training of a neurosurgeon. So I know a lot about the brain. Perhaps more about the brain than most neurosurgeons. All right, there's the tear again. It's just ongoing. This is all scar tissue from inflammation. And it's got calcium in it, which is the gold stuff. We're going to zap it out. Any more questions?
None currently.
We're going to be done in about 15 minutes with this surgery. For those of you that missed it earlier today, we did a posterior cervical laminectomy and fusion on a patient with 5 bad discs in their neck, 5 degenerated discs. One of them was actually operated on by a surgeon, not me. And that patient ended up with a lot of problems from the surgery because the surgery wasn't done properly the first time, which is why I encourage everybody out there, you can't just go to a spine surgeon and expect them to fix you. You have to go to the right spine surgeon, right? You can't just buy a horse and expect to win the Kentucky Derby. You need the best horse and the best jockey and the right equipment and the right training, the right team if you want to win the Kentucky Derby, not just a horse. Spine surgeons are like horses. There's a lot of old, tired horses that you're not going to win the Kentucky Derby, let alone make it around the racetrack a quarter mile. And then you've got superstars that are capable of immense results. I hate hearing people that think doctors are like cars. You know, it doesn't matter where you buy the car, it's the same. It's all manufactured the same way. It's not. Surgeons truly are more like racehorses than they are like cars. There's a lot of difference between them and their technique, how they do things, their ability, obviously. Stand by. See the pink stuff right there? That's all granulation tissue we're going to get to. That's where his pain's coming from. That's inflammatory tissue. That's what I'm going to get away with the laser. Zap it away. First, I want to remove some of these scarred up pieces of herniation. You see the pink a little better at 12 o'clock, right? Everybody see that? Yes?
Yes.
Luis?
Yes.
I thought you were colorblind. No?
No.
Just kidding. Oh, can colorblind people see pink? Honestly, I don't know. But I can see it right there. That is what drives this patient mad. Goodbye. Goodbye, pain. It's a beautiful thing. So if you don't know it yet, Deuk Spine Institute has an app. It's free. It's called Deuk Spine Institute app. If If you go to the App Store, type in Deuk, D-E-U-K, Spine Institute, and download the app for free. We have lots of interesting videos, testimonials, information about conditions of the spine, latest treatments, even an opportunity to get a free MRI review. And of course, updates, things like that through the app. We use the app in the office when patients come into clinic. We have all the patients download it, and then when they're seeing the doctor, we'll put on the app which diagnosis they have, and which treatments we're recommending. That way, the app becomes a little bit personalized for that patient. It's kind of a useful tool. And of course, that's stored in the app, so even if they forget what we told them in clinic, which they probably will most of the time because we tell them so much. Hold that for a second. No, let me just see something here. Yeah, we're getting close. See the tear right there? Look at that inflammation of the tear. Now notice how it's getting worse the further out to the periphery of the annulus I go. That's because the outer annulus is what has the blood supply and the innervation, not the inner annulus. So the further out I go in this tear, the more we're going to see blood vessels, pinkness, you know, and nerves, and it's going to be more sensitive to the patient. He may actually start moving around a little bit if he's light, which is fine. I don't mind him moving around a little bit. That's a beautiful picture of the granulation tissue and the herniation right there down the tear, down that crack. Just about done. So why do we broadcast live from Deuk Spine Institute? Because there's so much misinformation out there about chronic back and neck pain and whether it can be fixed or not. And most people don't know that it can be cured. And we think it's important that people know the truth. That's why we broadcast. There's so much misinformation because so many people have back and neck pain. There are supposedly 40 million people out there with chronic back pain. 40 million. In the United States, of course, I'm talking about, not worldwide. Worldwide, the number's bigger. Let's say 100 million worldwide, easy, with chronic back and neck pain. Those 100 million people are being told all kinds of nonsense by doctors, by nurses, by chiropractors, by therapists, by business owners that are trying to sell something. The truth is, we have the truth right here. We show you the truth every day. Show me one person who takes cannabis oil or whatever that's cured of their back pain. Show me one person that's had interventional pain management that's cured of their back pain. Show me one person that's had fusions out there, artificial discs, that's cured of their back pain. There aren't very many at all. If there are one or two, great. But the vast majority of people end up going on to have more and more pain. So the truth is that if the surgeon finds the right spot or spots to fix and they fix it properly, you can be cured of your back pain or your neck pain. I'm not the only surgeon that can do that. There's other ones that do it. But they have to treat all the painful discs that are there, not just one or two. They have to treat all of them. This patient has 3 painful discs. We tested all 3. Each disc had 10 out of 10 pain. Okay? And I didn't tell him when I was injecting the dye. I don't know if you noticed that. So he didn't know when I was injecting. And he suddenly tensed up his back and said, ah. In other words, we found the source of his pain without him knowing we were actually testing for it. He knew we were going to test at some point, but he didn't know when I was going to inject. So it's a blinded test, meaning the patient doesn't know when it's going to happen. They just kind of have an idea of when it's going to happen, but, you know, he's not going to fake his own pain. So we had a real good look at where the pain was coming from. And it was these 3 discs that we're fixing. All right, just about done, about 30 seconds left on this disc. I'm looking lateral now to the outside of the tear, back to the inside. Just about finished. This was a long one, folks. This is a big man. big, like muscular and bulky. So he's got a lot of big body parts. Okay, his discs are huge to accommodate his large stature. That said, his herniations are also big. So sometimes the herniation is quick and easy. Sometimes it takes a long time. This was a longer time one. And let's see if we can see the nerve. The nerve is right inside that tissue right there. So we're done. Herniation gone. I'm very happy. I think this patient's pain will be gone. And then he just needs to heal up. This hole right here will close off with the same material that the annulus fibrosus is made out of, collagen. Another name for it is scar tissue. Scope off. Huh? Yeah, we have the other side to do. We got one more to go. Just about done. Yeah, push pressure.
Yes, sir.
All right, let me come over there. Go ahead and get the fluoro in. Last one, L3-4. I'm going to the left side of the patient. Everybody in agreement? Let me hold that while you switch sides. Come on, bring that fluoro in. I'm putting pressure right now on the patient's back because we're trying to keep him from getting the bleeding. So I don't know that he's going to bleed at all, but whenever you put a tube in somebody's back, it could tear a vein in the muscle. And if I don't put pressure, the bleeding could get into the muscle where the tube was, and then it'll cause some irritation of the muscle. And that can last 2 weeks, 4 weeks, cause muscle spasms. So we don't want that. That's why the blood pressure has to be kept under control, which our anesthesiologist is definitely doing. And that's why I got to put pressure with my hand to keep any venous bleeding from coming out and affecting the muscle. Okay? Luis, you got it? All right. So we're switching sides. Whenever you're ready, you take your shot. All right, so you see we have one last disc to do. Guide wire goes in. Shot. I want to make sure it's in good position, and it is, so I'm going to take this needle out. By the way, somebody asked what's a percutaneous discectomy. It's when you take a needle like this and put in the disc like I did, and then put a laser fiber. Oh, let's do it. Give me the laser fiber. So you all see this, Sean?
Yes.
So a percutaneous discectomy is when you put the needle in like I did, and then you take the laser fiber and you go down like this. You see this? And you go, done. But guess what? It doesn't do anything. It doesn't work. It's just bullshit, basically. Sorry. But you got to know the truth. There's certain words that only express the truth. I can't tell you why doctors do that kind of stuff. I mean, I can tell you why, but I'm embarrassed to say why. But let's just say it has more to do with making money than it does fixing people, which is why we don't do percutaneous discectomy here at Duke Spine. We do endoscopic true discectomy. You see the incision that I just made? You don't make an incision when you do a percutaneous discectomy. There's no reason. It's percutaneous. Percutaneous means it's done through the skin with a needle. The moment you make an incision, it becomes a surgery, not percutaneous. So there's a lot of misunderstanding about that terminology for some reason. I don't know why. But relax. Why are you putting pressure in the middle? Shot. You're too funny, man. Too funny. Too funny. Okay, so the dilator's there, coming into the spine. We're literally at the facet joint anteriorly, and we're about to enter the foramen. I need some suspenseful music, please. Good. Thank you. Keep it going. Suspenseful music. I'm pushing against the herniation. Shot. What's the problem? What's the problem?
You want it higher up?
No, no, no. It just, I don't know what's going on there.
Just leave it there.
Yeah.
I don't want to get anything onto the field contaminated. All right. So here we are, shot. We are right against the herniation. I can feel it. This is the side he has. This is why he has left leg pain. Shot. It's very rubbery, just so you know. It's like bouncy. Like a, remember the old, I don't think they sell them anymore, the old rubbery balls that you buy out of the gumball machine?
Yeah, they
Remember the super bouncing balls? That's kind of what it feels like. Farg.
Eight and a half. Yeah.
Is that my latest picture? All right, I'm putting this here. I don't want to use it. And let's get a new glove. I don't know. I think it went through. Did it go through one or both? I'm throwing my glove on the ground. I don't think it went through the other.
Is that right side? Left side?
Left side. So I just got my glove pinched between the two pieces of metal
From back there.
as I was hammering.
Another set.
And it tore a hole in my glove, my outer glove. I don't need another set of gloves. Do I?
No, no, no. You need the.
Oh, no, I don't need that.
No?
I'm done. I'm done. So I was trying to tell you, I'm done. Shot. I'm just going to hold it in position, take out the guide wire, and we're going to go in this way, the old-fashioned way.
I think you still need it.
I what? Get out of here. Luis didn't tell you, but at 6 o'clock he becomes a comedic. Is it really 6 already?
6:13.
They say time flies when you're having fun. Oh, I guess I do need it. Huh. Sorry. You were right. I forgot I needed for this. Well, back to the drawing board. So we've already treated the, can you see this? Or is the glare too bad?
We can pretty much see it.
You can or cannot?
We can.
All right, we've already fixed L3-S1 and L4-5. We've got the giving birth to a child disc next, which was 10 out of 10 pain. Thank you, Luis. And that's where we're at right now. By the way, there's a lot of talk about whether these procedures should be able to be done by pain management doctors and rather than surgeons. And my opinion is no, not unless the pain management doctors had the proper training, surgical training. So take a look at Dr. Patel. My Dr. Patel has been a surgery assistant with me for years. So he's done surgery. Most pain management doctors have not. 99.9999% have not done surgery. Dr. Patel has. So would Dr. Patel be acceptable to be a surgeon that does endoscopic spine surgery? As long as he's trained properly, yes. But
Scope on, please.
unless the pain management doctor has had surgical training and privileges in surgery, they should not be doing these procedures. Just because they're a small incision and minimally invasive doesn't mean that they are a pain management doctor's procedure. They're actually harder to do than open surgery. I just make them look easy. All right. Lay still. He's coughing. Wheezing? All right. We're almost done. So just keep him comfortable for a little bit longer, and then we'll be done. Laser. All right. Like I said, we're just about there. been a long surgery, obviously. Like I said, there was a lot of herniation, a big herniation, big discs. Big man, big disc, big herniation, big tear. So it takes longer. It's all proportional. Everything okay? What's that? Do you need some help over there?
Can you call another nurse, please? Over here.
Yeah, I agree. Bring another nurse. Just to be safe than sorry. Yeah. You don't need to put them deep. I can have them lighter for a few minutes while I'm working inside the disc.
No, it's just the way his head was laying on.
Oh, okay. Do we make sure he's comfortable before you put him to sleep, Luis?
Yes, sir. Yeah, yeah.
I'm going to have to fix this a little bit and make it prettier. Laser off?
No, stand by.
Standby, I mean. Off, standby. Isn't it the same? No? It's different?
Well, yeah.
What's the difference?
I think off is going to turn off.
Shut the machine down. And it's got to warm back up again.
Yeah.
All right, folks, we need some questions from the audience. Sean, let's see if you can generate some questions from the audience. Yeah, gosh. So look at this. A lot of the dye has already been metabolized, or it's leaked out, or it's been disseminated out of the disc. So mostly it's white at this point because we did the injection so long ago. Remember? Now the dye is pretty much gone.
We have a question.
Sure. Thank you. Whoever's asking.
A viewer from Periscope is wondering, what are some of the hazards to the surgeon when doing this procedure?
Hazards to the surgeon. That's great. I like that question. Nobody's ever asked that question before. So the biggest, most obvious hazard is the radiation from the X-ray machine. It's a hazard to the surgeon and the patient and the staff, everybody. If you're 6 feet from the X-ray machine, you're getting radiation that's significant. So we actually wear leaded gowns during surgery. You can't see it maybe on me, but if you look carefully, you'll see I have a collar around my neck. And that's, it's not because I have strange fetishes with collars. It's because it's a lead collar. It's protecting my thyroid. The thyroid is the most radiosensitive tissue in the human body, and you can get thyroid cancer. Whoa, that's a big herniation. You want to see this one here? It's kind of cool. Sean, you see it?
Yes, we can.
Should I put it against the blue? You can see it better? Look at that thing. It looks like a slug. Here, take it. So the thyroid in the neck is the most radiosensitive tissue, and you get cancer, which sucks if you get it. So that's a hazard. Another, of course, is our eyes. We could damage our retina with the laser, but also you get cataracts on your lenses, the lenses of your eyes from radiation. And I don't want cataracts either. So the radiation causes thyroid cancer, it causes cataracts, and the laser can cause damage to your retina where you could be blinded. If I accidentally turn the laser on and shoot it around the room, it'll be like Star Wars. Other hazards include, there's a herniation right there, include gases in the operating room that I could be exposed to, anesthetic gases. Stand by. For example, if the machine is releasing gases during surgery and we don't know that, could be bad. Oh, there's another herniation. Good size. These are the herniations that I shoved back into the disc. when I put that tube in, or the dilator in, I mean. Yeah. I could cut myself with a knife. Obviously, we're using a scalpel. And I've fortunately never done that. In 25 years of operating, never cut myself. But I know other doctors who have. I could accidentally cut Luis. He's making me angry. Of course, it would be accidental. So that would be a hazard to me in a way, because Luis would probably punch me. You know, I could, the laser could go off and get me in my finger. And it's done that before, where it blew a hole into my finger. How are we doing on irrigation, guys? So, I'm still going on the hazards, by the way. Sweet Jesus, that's a big herniation. Woohoo! You hear the suction? That was cool. Get a picture of this one, Sean. Get the light on.
Light on, please.
That's a big one. You see that? Sean, you see that thing?
Yes, we do.
All right, here. All right. All right, so another risk is electrocution. I could get electrocuted because there's water on the floor. Hi. Are you finishing up for me? Yeah, thanks. We're almost done. This is our last disc. And it's going really well. You can see the tear right there. So I could be electrocuted because there's water, which has salt in it, right? Because it's lactated ringers or normal saline, one or the other. It's got a lot of ions, and water with ions conducts electricity very nicely. So this room is a special room in the surgery center. It has a special circuit interrupter that if it appreciates any stray charge, it'll literally shut down the electricity before anybody gets zinged. So electrocution, injured with a laser fiber to my body or my eyes, radiation of my eyes, my thyroid, sarcomas we talked about earlier, which is tumors from radiation involving the musculoskeletal system and soft tissues, blood vessels. Oh, what else? Anybody? This light above my head could fall on my head, cause a concussion. There's a bunch of risks. Those are the main ones. Oh, and cut myself with a scalpel we talked about, or, oh yeah, poke myself with a needle. And of course, there's always the communicable diseases. So for example, if the knife that I cut myself with has the patient's blood on it, and that gets into my body, I could get a infectious disease, communicable disease, like HIV, AIDS, you know. I could get hepatitis, B, C, BCD, and any other type of virus. The gases of the anesthesia cart we talked about. Am I missing anything? Huh? Yeah, I talked about the laser breaking and zapping my finger or my eyes. So those are pretty much it. There's about 20 different things that could harm the surgeon during the surgery, of course. I could hurt my back lifting the patient. Oh, this just goes on and on. But that's what we're here for. Look at that tear right there. Bad. But we're going to fix it. We're almost done. I need about 5 minutes.
We have another question.
Yes, of course.
Someone on Periscope is wondering, what's the maximum number of discs you can do in a single surgery session?
The maximum, so what's the maximum number of discs, herniated discs we can fix in one surgery session? The answer is 4. But there's a qualifier to that. If we go to one side of the disc, we can do 4. So remember, every disc has a right side and a left side. I'm just talking about going to one side. So if we did all the right side or all the left side, I could do 4 discs. That's another big herniation there, I think. Now, if I was doing both sides of the disc, I could do 2, both sides. So basically 4 spots, 4 tears. 4 herniations that I could repair at one sitting. Could I do a 5th one if I had to? Sure. You know, but you see how long these take. They can take a long time. So, you know, you just have to be careful with the patient, and you don't want to overdo it and have them, you know, under anesthesia for too long. But I think we could safely do 4 discs. The truth is that most patients, the average is 2.4 discs per patient that need treatment. So for most people, it's really 2 discs, maybe 2.5 that need to be treated. So it's rare that we ever have anybody that needs 4.
And you put it inside?
This patient definitely needed 3 done. We tested those 3 and he had 10 out of 10 pain at all 3 discs. So I'm glad we did all 3. Because I think he's going to be really, really good when we're all done here. He's going to be very happy. Let me have the grabber again. Laser standby. Great question. By the way, I love the questions. Right, Luis? We like questions. We like questions. It's amazing how the dye has just completely left this disc. There's really nothing left from a dye standpoint. The blue is gone. This is what it would look like if I had to do these surgeries without the blue dye. It's just white, everything white. Makes it harder to see. But still, I can still see what I need to fix. In the beginning though, it's very helpful to use the dye. Again, this is lateral.
Chelsea, thank you. Thank you very much.
Is Chelsea leaving?
Yes, Monica's
Oh, Chelsea, good night. Great job, by the way. Did you enjoy it?
Yes.
All right. Good. You gonna come back?
Yes.
All right. Have a good night. So nice to have staff that love doing this stuff. It makes a big difference, right?
Yes, sir.
Sorry, folks, I can't speed this up. It's just this patient has massive herniations. I'm wondering if I can grab that piece out. So Monica, is the ball in our court for the MRI? So we need to get back to them? And did you find out from that other company?
Not yet. I'm waiting for them to call back. I did try again today, but got nobody.
So you know what we want to find out.
I'll try again tomorrow.
Can they service that machine?
Right.
I need the laser on, right? And if so, how often do they recommend it and for how much? All right, just about done. Can kind of see a light at the end of the tunnel here. We're just about at the surface of the disc, the herniation, the tear, the annular tear. We're just about at the surface right here. I can see some annular fibers, posterior longitudinal ligament fibers. The annulus has been torn. This disc has just been blown out bad. And just in this area. So the whole disc is not bad. It's just this blowout here. This is like a part of a tire that blows out, and we're here repairing it. So this patient's left L3-4 disc has been badly injured, and we're just cleaning it up, and the body will heal itself. That's the beauty of the surgery, you know. It's a natural repair of the disc. All I'm doing is cleaning things up to allow the body to do what it's supposed to do. Normally, people with disc herniations that don't have symptoms, they've healed up their herniation themselves. That's what you're supposed to do. That's what probably 95% of disc herniations, the body heals it themselves without surgery. And the symptoms go away on their own. But in some people, they just cannot heal their herniations. And it won't be all their herniations they can't heal, it's just a couple. So this is a herniation this patient could not heal. All right, we're pretty much done. I want 30 seconds. Okay. "30 seconds, Doc. You got that? All right. You live close by, don't you? Where do you live? Huh? Key West. Key West? The heck? Are you kidding me? Holy mackerel. That's far. I thought you were close by, Laser. My God, you got a long drive. You're chief of staff? Of anesthesia?
I have a question.
Yeah. Okay. All right. You're having fun. I like that. And we're having fun. Which one? Cape Canaveral? Wow. We're done. Beautiful. At 12 o'clock is epidural space with fat, and the herniation's gone, and his nerve root will be up here. You can actually see it, the blood vessels on the nerve root right there. That's dura around the nerve root. Pretty cool. Done. This patient's pain will be gone. We are in the business of fixing back and neck pain here at Duke Spine Institute. Scope off. Okay, folks, another successful surgery. No complications, and shoot, I can't remember how much blood loss. Maybe a CC? Oh, look at that. All right, you ready? You're not driving home tonight, are you? You gonna? Oh, that's right. Tomorrow's Wednesday. I apologize. I thought I was the only surgeon here. Are you getting all this stuff?
Yeah. Thank you.
No, thank you. Let's just show everybody real quick. I'll take the question in a moment, Sean. I'm going to come over there and answer it face to face. I want to look my questioner in the face. Actually, they'll be able to see me. All right, there's one incision. There's the other one. Put some pressure. It's a wrap. And we're going to check on this patient in about 30 minutes when they're ready to go home. Ray Tech off the field. I'm heading over there to answer the question. So type up your questions for me. This will be your last opportunity for today. And maybe I'm back next week. I don't know if I have surgeries next week or not. my beautiful face over here?
Yep, you're on. You're live.
Okay. Sean and I are having fun here at Deuk Spine Institute because that's what it's all about. You gotta love what you do, enjoy it, have fun doing it. So we have a question, Sean. What is it?
One of our viewers on Periscope is just wondering about your opinion. How do you feel about the USMLE going towards pass-fail?
USMLE going to pass-fail. Interesting. Well, I'll be honest with you. It's the first I heard about that, but that's the USMLE is the United States Medical Licensure Exam. Pass-fail. You know, I'll be honest with you. I think if the USMLE goes to pass-fail, then people will spend a lot less time studying because it'll be probably easier to pass. I don't like it. I don't think it's right. I don't think anything that takes away from effort and determination is going to help us have better doctors in this country or anywhere. You know, medicine isn't perfect. I don't think it ever was. I don't think we've ever found the magic recipe, but I will tell you this. If the USMLE had a pass-fail, I probably wouldn't have studied so hard, and maybe I wouldn't be where I am today. Think about that. What drives people is competition. Let's face it, competition is important. It motivates people in ways that are good. I mean, it's not everything, trust me. You can't just compete. You got to have a purpose for competing. You got to have love, passion, determination. You have to have respect. And if you have all those magic ingredients and you compete, you can do amazing things as a human being. But I think pass-fail system is taking a step backwards. You know, I just think it's a mistake. That's my opinion. What other questions?
What was it?
Okay, so great question, and I want to say thank you to everybody out there that asked questions. I like questions for a couple of reasons. Number one, it gives me something to talk about. Otherwise, I just start talking about all kinds of things maybe you're not interested in. But importantly, we use questions to teach. We use questions to understand better what it is we're dealing with. And questions are a good starting point, a springboard for discussing ideas and thoughts and challenges. So I like the questions. I think they're good. They're a good lead-in for me to talk about topics that are related to spine surgery and spine. So I appreciate the fact that everybody asked those questions, and I like answering them during surgery. We hope that everybody out there is learning something new about the spine, about the back, the neck, and I don't know everything there is to know. I'll be the first person to tell you, but I do feel like I know a lot when it comes to what are called degenerative conditions of the spine. Degenerative are problems with the discs, the joints, as opposed to trauma. Well, not really trauma. Trauma is a bad example because degenerative is from trauma. It's just not like car accident trauma or falling off a roof trauma. The trauma injuries to the spine are not that common. The big traumas like car accidents and falls. But all of the degenerative conditions that affect the spine, herniated disc, bulging disc, spinal stenosis, facet hypertrophy, arthropathy, radiculopathy, all that stuff that we deal with every day, those are all due to trauma. Trauma to the disc and the facet joints. So my business is trauma of the spine. It's just not the kind of trauma you think of ambulances and helicopters and jaws of life. But the other conditions of the spine that I don't really treat here at Deuk Spine include most of the metastatic cancers to the spine. If somebody has lung cancer and a piece breaks off and goes and eats away at the bones in the spine, I usually don't. I mean, I can deal with that at Deuk Spine. We can do it outpatient, but we're limited. infections of the spine we typically don't treat here. But 90% of spine surgery and spine care is more degenerative conditions of the spine, which is what we do here at Deuk Spine. And the cases we did today were all degenerative, trauma degenerative. Our first case was a PCDF. That went well. We saw some kyphosis. We were able to reduce the deformity a bit. We got the pressure off the nerves and spinal cord. We got the screws and rods in. I wasn't happy with his bone quality. He does have some osteopenia, maybe even osteoporosis in some of those bones. When you have osteoporosis, the screws don't hold very well in the bone. So you have to be very careful trying to correct the deformity of the spine when the screw bone interface is compromised because the bone quality is poor. We did a laser surgery on a gentleman who's had pain for 5 years. His pain was gone at the end of the surgery, and he was very happy. We did an interview on him, and that will be published tomorrow. So look for that tomorrow on the Spine Surgery Support Group and Deuk Spine Institute website, Facebook. And then the last case we did was a 3-level Deuk Laser Disc Repair, L3-4, L4-5, L5-S1. The patient has back pain and pain going down both legs. I determined that the L3-4 disc herniation was more on the left side on the MRI. It looked like it was irritating the left L3 nerve root, L4 nerve root on the left side, so I went to the left side at L3-4, and then at L4-5-5-1, I went on the right side, the opposite side, because the herniations looked like they were more to the right side on those discs. We tested the discs. They were 10 out of 10 pain, all 3 of them, and that was the pain the patient has every day. So I feel really good that now his pain's going to be gone. And we're going to have another video of him before he leaves today, where you'll see him up in about 15 minutes. We're going to get that video before he leaves, and I'm 99.9% sure his back pain will be completely gone. I've done this surgery 1,300 times, and the pain is always gone. It's amazing. And the only time it comes back is if people re-injure that disc. So most people don't re-injure their disc after I operate on it. 99% of the patients go on and don't have a problem. It's the 1% who re-injure their disc, and yeah, they end up having the pain come back and they need another surgery. So the Deuk Laser Disc Repair has a 1% reherniation rate and like a 1% reoperation rate. Any more questions? I've enjoyed my time with you all. Hopefully you learned some interesting things today, and we'll see you maybe next week. What do we have next week?
I don't think there is anything next week as far as right now.
Nothing next week. So if you want to get your back or neck fixed, you better get out here soon, because I'm not getting any younger.